Good morning, everyone. It's my pleasure to welcome you to all this important and insightful webinar on MDS. I am Prashant Agrawal, and on the behalf of Adley Oncology team, I would like to extend my warm welcome to Dr. M.B. Agrawal, our esteemed speaker, Dr. Maria, chief guest, Dr. Pooja, all discussants, and all participants. I'm thankful to Dr. M.B. Agarwal for giving us this opportunity. And now, on the behalf of Adler Oncology, I would like to give a brief introduction about the company with the permission of Sir. Adler Oncology is one of the fastest growing company in India and one of the widest, which is having the widest range of anti-cancer drugs in India. It has established its name in oncology market because of its persistent efforts and the trust of the clinicians like you. Adler Oncology is having the widest range of anti-cancer formulations and the APIs. Adler Oncology always focus on the research and development to meet the cancer needs. As I told you that it is one of the fastest oncology company in India. It is having the footprints in more than 46 countries and having the presence in more than 85% of corporate and the government hospitals. Not only this, it has been accredited by many international accreditations like INVIMA, ANVISA, PICS, and EAEU. The company is having more than 135 plus products in oncology basket, and it is having a strong pipeline ahead. In the last 5 years, Adler Oncology has established its strong presence in hemato-oncology segment as well. In 2019, it has launched Bidan, the dasatinib first to launch. Then it has launched the azacitidine tablets. That was also first to launch. After that, carfilzomib, eltrombopag, nilotinib, acalabrutinib, that is betatinib, and many more. Now, today, we are having the rich portfolio in hemato-oncology basket. I would like to tell you that now the wait is over. We are launching soon imatinib oral solution 80 milligram per ml. It will be available in next couple of days. It is a targeted therapy for CML and Philadelphia positive ALL. It will provide the flexible doses in the pediatric patients and provide the patient convenience. We are having the patient's first approach, and this is the guiding principle through providing the patient's compliance, patient support, patient education, and the cost-effective medicines to all the cancer patients. Moreover, we would like to help needy patients through patient assistance program that is very easy and the fast. So with this, I'm sure that we will be able to serve more number of cancer patients in India and globally. Thank you very much. Now I hand over the session to Dr. M.B. Agarwal, sir. Over to you, sir.
Well, thank you so much for that kind introduction. We are always grateful to Adley for joining us for these academic activities of Mumbai Hematology Group. Good morning to one and all. Our guest speaker this morning is Dr. Maria Campello from Spain. She will be speaking to us on an update on MDS. This webinar is brought to you by Mumbai Hematology Group, supported by Adley and managed by Perfect Square. I thank Mr. Ashutosh Shukla and their team from Adley, Mr. Yash Kalpesh and team from Perfect Square, the Executive Committee of Mumbai Hematology Group, our chief guest today, Dr. Pooja Prasad from Punjab, our guest speaker, Dr. Maria Campello from Spain, all our discussants who are eminent hematologists or hemato-oncologists or even medical oncologists and hematopathologists, and you participants for sparing your Sunday morning, afternoon, evening, depending upon which part of the world you belong to. To tell you something about our next weekend activities, on next Saturday in the evening, 5:30 p.m., we have Dr. Jeevan Garg speaking to us on pentarefractory myeloma, its management. And this will be followed by the pathology of Hodgkin lymphoma and how to distinguish from its mimics by Dr. Kekri Naresh from Fred Hutchinson, Washington, US. Sunday morning, 11:30 a.m. and UK time 7 a.m. we have Dr. Austin from King's College Hospital, London, speaking to us on management of aplastic anemia in 2025. We have a galaxy of discussants today from various parts of India, and they are put up over here alphabetically. And I'm grateful to them to spare their time and be available to discuss with our learned guest speaker today. A brief introduction of our guest speaker. Dr. Maria Campello is Associate Professor in the Department of Hematology at University Hospital of Salamanca, Spain. After graduating from medical school in 1999, she started the medical training in hematology. Since 2005, she has been working in the Department of Hematology at the University Hospital of Salamanca in Spain. Between 2006 and 2009, she completed a 3-year postdoctoral fellowship provided by ISCII. From 2009, she was responsible for the section of morphology and hematimetry in the hematology department, and since 2017, she held a position of Associate Professor of Hematology at the University of Salamanca. Since October 2016, she is heading the MDS team at the University Hospital of Salamanca. Her clinical expertise lies in hematological malignancies with the focus on MDS and AML. The main scientific interest involves the translational exploration of innovative treatment options for these patients. She is a member of the Spanish MDS group since 2009 and heads this since 2018. She is also involved in the European MDS Cooperative Group. Today, she will speak to us on myelodysplastic syndrome and update. And before she does that, let me introduce our chief guest who is going to inaugurate our webinar today. And that's Dr. Pooja Prasad from Punjab. Dr. Pooja Prasad, everyone knows her, but I'll complete the formality. She is currently serving as an associate professor in the Department of Medical Oncology, Adult Hematolymphoid at Homi Bhabha Cancer Hospital and Research Centre, Punjab. With a strong foundation in both clinical hematology and pathology, she has over a decade of experience spanning academic institutions and tertiary care centers. She earned her MBBS from Vardhaman Mahavir Medical College and Safdarjung Hospital, Delhi, followed by an MD in pathology from PGI and Dr. RML Hospital, New Delhi, with gold medal. She completed DM in clinical hematology from NRS Medical College, Kolkata. Subsequently, she was assistant professor at VMMC and Safdarjung Hospital, New Delhi, and then associate consultant in hematology and oncology at Fortis Hospital, Mohali. Throughout her career, she has been actively involved in the diagnosis and management of hematological disorders. Her clinical proficiency lies in hematological malignancies with a focus on lymphomas, MDS, and AML. She is a member of several professional organizations, including the Indian Society of Hematology and Blood Transfusion, Indian Association of Pathologists and Microbiologists, and multiple regional hematology societies. I request her to inaugurate our webinar and give some words of wisdom for our students and all of us, in fact.
Thank you, sir, for the kind introduction. And good morning, everyone. It's a privilege to be here today as a chief guest of this webinar and to speak with so many young, bright minds. At the outset, I would like to express my heartfelt gratitude to Dr. M.B. Agarwal for the kind invitation and providing the honor of sharing this platform with Dr. Maria Campello. As we all know, Dr. M.B. Agarwal, sir, is a stalwart in hematology, and his continued efforts to educate and inspire everyone around him is commendable. He truly embodies the ethos of curiosity, passion, and perseverance, the very values that hematology represents, and I believe strongly in. I often get asked why I chose clinical hematology after completing my MD in pathology. Well, I was fascinated by the microscopic world, the patterns, the way a single slide could tell such a complex story. A simple peripheral smear report, which could bring despair, and after treatment, the same report could carry So much hope and joy. But over time, I began to feel a pull towards the human side of that story. I wanted to be a part of the full journey, not only the diagnosis, but the decisions, the treatment, the long term care, and survivorship. And clinical hematology offered me that bridge. It's a very unique specialty where lab science and clinical medicine are deeply intertwined. What you see under the microscope directly shapes the decisions made at the bedside. I saw firsthand how a timely and accurate diagnosis, coupled with prompt evidence based treatment, could dramatically alter outcomes and, in many cases, save lives. If there's one thing my journey has taught me, is that curiosity opens the door, but perseverance keeps you going. There were times during my residency where I felt overwhelmed by the volume of information, the ever evolving hematology landscape, the emotional intensity of patient care, the pressure of making the right call. Even now, there are times while I'm practicing at a tertiary cancer center when I've seen protocols fail, diagnoses remain elusive, and patients just not recovering. In those moments, I try to remember that every challenge is also an opportunity to learn, to grow, and to serve with greater empathy. And hematology teaches all that. Healing is not always about curing, it's also about caring deeply and consistently. So, to all the young minds here today, whether you're just starting out or you're trying to decide which direction to take, I want you to know there is no single right path. Some of us choose to be researchers, some go on to become clinicians, either after doing our MD in medicine, pediatrics, or pathology. Some move on to become hematopathologist or transfusion specialist. I would like to emphasize that every path is valid and every contribution matters. What unites us all is perseverance. So stay curious, keep asking why, and continue learning even when it gets hard. You'll find your way. Thank you once again. And a special thanks to Dr. M.B. Agarwal for this opportunity to reach out to you today. And welcome, Dr. Maria. It's an early morning for you, but I'm really excited to listen to some MDS updates. Thank you.
Thank you, Pooja, for sparing your time and being with us. Beautifully crafted speech with full of messages. Thank you indeed. And now over to Dr. Maria for her lecture, and we're all going to listen to her. You're muted, Dr. Maria.
Thank you. Thank you very much. Good morning. In Spain, it's my pleasure to be here with you. Sorry, because I'm trying to open my and share my screen. Oops. Sorry, I'll try to do it again. Yes, this is last problems of the direct. Okay, I'll try to share my screen. Can you see it? Yes.
You can see your screen now.
Yeah.
Perfect.
Yes. Sorry for these problems, last minute problems. Thank you, Dr. Agarwal, for inviting me to participate in these amazing meetings. It's amazing to be here on Sunday with all of you. And today I'd like to share the last updates in MDS treatment. This is an overview of the new drugs and the new clinical trials ongoing in this subset of patients. And let's start with this overview. We are going to address not only lower risk MDS management, also high risk updates. Nevertheless, in this second part of the speak, as all you know, there is no very good news to the last for the last months due to the fact that all clinical trials recently have failed, but we have to comment also on it. Let's start with the lower risk MDS management, and here you can see a brief overview of my presentation of this part. The first thing that I think that we should address is the definition of lower risk MDS, because it's important to note that we have to carefully identify lower risk MDS patients. And we identify in the Spanish team of MDS, the GSMD team, that MDS with a lower risk profile are those patients with overall survival expected to be superior to 30 months. And these patients are categorized in the lower risk setting, not only at diagnosis, also during disease evolution. It's very relevant to take this into account. Of course, lower risk patients are those that are going to be in the lower categories of the classical prognostic indices like IPSS or IPSS-R. And we have to take care with these intermediate categories because sometimes in these intermediate categories, we have several patients not in the lower risk category due to the fact that if the patient is presenting with in the intermediate categories and adverse cytogenetics or even severe cytopenias or other adverse features like molecular features, probably this is not a very low risk patient. Importantly, we also have to take care with patients that are in the lower risk categories and have an early failure to the current treatments available like ESAs or lenalidomide. So if the patient is failing pretty soon after the treatment initiation, probably they are not in the lower risk category. And of course, due to the fact that now we have molecular markers in this disease, we are going to be able to better classify patients according to the molecular IPSS, and we define in the lower risk categories those related to the low risk, moderate, low IPSS, and very low. When we have patients within the lower risk setting, we have to take this progression map into account because the majority of the patients with the lower risk MDS are not going to progress to higher risk MDS and to AML. The majority of them are going to keep on lower risk setting and they are going to develop severe cytopenias, the majority of them anemia, and this anemia, and especially when this becomes transfusion dependent, is the cause of death in the majority of the patients and is not only responsible for the poor quality of life, it's also responsible for the deterioration and appearance of different comorbidities, and due to the iron overload, when the patient becomes transfusion dependent, the different organ toxicities occurs, and finally the patient is dead due to this cytopenia consequences. So we have to take this into account because the majority of the patients need to be treated not to avoid transformation of a higher risk MDS. They need to be treated to improve anemia, improve this cytopenia in order to improve overall survival. And here you can see the treatment goals in this setting. The majority of the patients are going to develop anemia. The majority of them are going to become transfusion dependent, and we need to treat the patient, as previously commented, in order to increase hemoglobin level and reach transfusion independency, because this anemia is going to significate for the patient poor quality of life and poor overall survival. We have to take care with these patients because treatment characteristics in these patients are different from other hematology patients, and we have to take into account that the majority of them are being older patients, and the majority of them several times presented with comorbidities. So the treatment that we are needing in this subset of patients need to have or mandatory a very favorable profile. Regarding safety, we don't need treatments that decrease quality of life per se, and of course, administration of this regimen needs to be reasonable. So these are specific characteristics to take care, and we have to be cautious with, especially in this lower risk setting. Here you can see the treatment algorithm for the American College according to this lower risk setting. This is the last version in 2025. And as you can see here, we have for the treatment of anemia, that is the majority of the presented in the majority of the patients, and the majority of the patients with MDS need to be treated for this reason. We have three subgroups of patients. NDS with del5Q and low blast. In this treatment, the preferred treatment, as all you know, is lenalidomide. The second group is this related to mutation is SF3B1 and ring sideroblast present. And in this subgroup of patients, luspatercept is the main treatment in first-line treatment in the majority of the patients. But we have also several other available therapies nowadays, like imetelstat, ESAs, of course, and is becoming in a specific subpopulation of patients target therapy of mutant IDH1 and with mutant IDH1 drugs. And finally, in this last group of patients with no SF3B1 mutations and no del5Q, this is a mix of patients with different prognosis in which we have several other available drugs, and the same drugs with different indications. So we are going to review in this during this next minutes this treatment choice, starting with del5Q. Here you can see the last one of the last algorithms for these patients, and here you can see the European approach for the treatment of lower risk NDS patients is presented in this year by Dr. Plattbecker in the paper in a very good paper in Hematologica. And here you can see that for patients in del5Q, we have to identify that lenalidomide is the preference treatment of choice and is approved when the patient is in the transfusion-dependent phase of the disease. And it's important to take care because we sometimes identify the patients in the non-transfusion setting when the patient is only anemic but no with transfusion dependency. And in this setting, lenalidomide at low doses could be an interesting drug to be treated. And this is based for this clinical trial that we have performed in Spain and in Europe during the last years. And we try to identify if low dose of lenalidomide is of interest in patients with anemia and no transfusion dependency due to the fact in order to try to delay the development of transfusion dependency. And in this population of 60 patients, we randomized that were included in the clinical trial. These patients were randomized to receive lenalidomide or placebo, as you can see here in this scheme. And we included patients with lower risk MDS and anemia, no transfusion dependency, and with the patient of del5Qs as isolated or plus other additional abnormality. The patients were randomized to receive lenalidomide at low doses, only 5 milligrams per day, as compared to placebo in a 2:1 ratio, only for 2 years of treatment. And after that, all patients were discharged and started a follow-up period. Here you can see the results of this treatment, and we can confirm that with low doses of LEN, we are able to delay and decrease the transfusion dependency. And as you can see here in the figure, a low proportion of patients receiving lenalidomide only for these 2 weeks become transfusion dependency, and the median time to transfusion dependency was not reached as compared to only 11 months for those receiving placebo. So with this idea in mind, with this treatment, we are able to decrease up to 70% the risk of transfusion dependency. Interestingly, we also analyzed the rates of the erythroid and cytogenetic responses, and we identify that these responses are even greater than when we use the drug in the transfusion-dependent setting. And the majority of them, as you can see here, specifically in cytogenetic response, reach cytogenetic response. Overall, 94% of them reach cytogenetic responses, and the majority of them in a complete cytogenetic response. So it's amazing to see how, if we anticipate the treatment, even with lower doses, are going to improve the results that when we treat the patient later. Here you can see the toxicity. Of course, they develop several times hematological toxicity, but the majority of them were in grades 1 or 2. And when the patient developed grade 3 or grade 4 neutropenia, it's only a minority, and they don't translate in clinical consequences like febrile neutropenia. We have to take care in these first cycles, and after that we don't have any issue related with this. So the idea in this patient is like we have in the other general setting, is to early treat patients before transfusion dependency to reach better, more benefit than we treat the patient later. Let's move to luspatercept. Luspatercept, as all you know, is a novel target and a novel drug available for these patients. It's a TGF-beta inhibitor that is approved for patients in transfusion dependency. And here you can see one of the first clinical trials in which we see the benefit for transfusion-dependent patients with anemia in second line in patients with SF3B1 mutation or the presence of red sideroblasts. The Medalist clinical trial was published in 2020 in the New England Journal of Medicine because it make a historic hit of changing the paradigm of treatment in this setting. In this clinical trial, we included lower risk MDS patients with transfusion dependency after ESA failure, and the patients were randomized to receive in a 2:1 ratio luspatercept at a started dose of 1 milligram per kilo, and with the possibility to increase dose up to 1.75 as compared to placebo. And this drug is administered subcutaneously every 3 weeks. The primary endpoint was to reach, as all you know, transfusion independency for more than 8 weeks during the first 6 months of treatment. And as you can see, near 40% of the patients reached this goal in the luspatercept arm as compared to placebo. The median duration of the response of this transfusion independency was around 7 months, and interestingly, this drug has a very favorable safety profile with no relevant or frequent or severe adverse events. The majority of the patients that developed adverse events were related to gastrointestinal disorders, sometimes hypertension, but they are generally in grades 1 or 2. Interestingly, when we analyze different data of these clinical trials, we identify that this starting dose was not always sufficient to reach responses, and the patients need to increase to the dose up to 1.23 or 1.75. And is of special interest in the high transfusion setting, because when the patient has a very high transfusion burden, the majority of the patients required to increase the dose up to the maximum tolerated dose in these patients, that is 1.75 milligrams per kilo. And as you can see here, the majority of the patients that respond in the high transfusion burden setting was those receiving the higher dose. And this is one of the reasons because two different clinical trials are currently ongoing, the Maxilus and the Luz Plus trials that we are going to comment in a few minutes, in which we use this drug starting in the maximum tolerated dose of 1.75 milligrams per kilo in order to try to increase responses in this population. The second clinical trial for luspatercept in transfusion-dependent anemia was this one, and this treatment was put on first line. In this setting, the patients were transfusion dependent, and they have not received previous treatment. The patients were randomized to receive luspatercept at the same doses and escalating scheme as compared to the current available treatment that it was EPO-alpha. And interestingly, the primary endpoint was a composite endpoint, and during these 24 weeks, the patient need to reach transfusion independency, but for a prolonged period of time, 12 weeks, and with a concurrent mean hemoglobin increase of more than 1 gram per deciliter. That is translated in a probably better outcomes for the patient. Here you can see the final results of the clinical trial, published also in two relevant papers, The Lancet and Lancet Hematology. And we identify that near the double of patients receiving in first line luspatercept reach this goal of transfusion independency plus increase in hemoglobin level of more than 1.5 grams per deciliter. And yes, 60% of them reach this goal as compared to only 35% in those receiving EPO-alpha. And this made that this drug was also approved for the authorities for the treatment of all types of lower risk NDS patients with ring sideroblast positive and negative in first line treatment. And this was also due to the fact of this drug was better when we analyzed different scenarios. According to the baseline transfusion burden, the benefit was greater for patients receiving luspatercept in rest as compared to ESA in gray. Also, the results was better and was independent for the baseline endogenous EPO levels. You can see here also the graphs. And interestingly, when we analyze SF3 mutations and ring sideroblast status, we can see that the majority of the benefit was reached for patients in the positive ring sideroblast status or SF3B1 mutations. And according to the ring sideroblast negative, the patients that have not this ring sideroblast have similar rates of responses when we analyze luspatercept at ESAs. Nevertheless, the duration of the response, as you can see here in the slide, is greater and is prolonged when we use luspatercept as compared to ESAs. And this is the reason why this drug was also approved for the patients of ring sideroblast negative. Its responses are similar, but duration of response is greater than ESAs. And here you can see the median duration of the response with luspatercept. The overall duration in the overall group is superior with luspatercept, and specifically in this subgroup of patients. Again, safety with this drug is confirmed, and here you can see a resume of the adverse events reported, and importantly, there are no relevant or severe adverse events related to this drug. Is pretty similar to EPO-alpha, and this drug also did not increase the progression to high risk AML or increase death. That is important. In the last EHA meeting, we have an update of this common trial, very important for the patients, because for the first time in a clinical trial with lower risk setting, we identify a benefit to treat the patients according to overall survival. And here you can see the long-term follow-up of the COMMANDS trial, in which we confirmed that overall survival is superior for patients receiving luspatercept as compared to ESAs. And here you can see the graphs. Here you can see for patients with more than 2.5 years of follow-up, we identify that those receiving luspatercept have better overall survival, not median nor reach, as compared to those receiving EPO alpha, median of 46 months. And this is the first time, I think, and it's very relevant, this result, because it's the first time that we see this improvement of overall survival, and this translates the idea that we need to treat very early patients with a very effective drugs in order to have an improvement, not only in quality of life, transfusion independency, but also in overall survival. And what is the next for luspatercept? As I previously commented, and based on the analysis of this data, we identified that it's probably better to start with higher doses at initiation. And in this regard, the EMSCO platform is developing a clinical trial called LUS+, in which, with the same inclusion criteria that the Medalist clinical trial, starting the treatment with luspatercept alone at these high doses, high level, 1.75 milligrams per kilo every 3 weeks, with the idea to compare the results with the Medalist trial and to see if we are able to increase responses, and probably these responses could be even or reach before earlier. And the second clinical trial with luspa at higher dose is this one, that is in the MAXILUX trial. And this clinical trial is developed by the company BMS in 2 cohorts of patients. One is like the COMMANDS trial in ESAs naive, first line treatment, luspatercept as monotherapy at this starting dose of 1.75, and in a second cohort of relapsed refractory patients, different from the Medalist trial, because included not only ring sideroblast positive, also ring sideroblast negative patients. It's important to take note because the first studies, the first results has been recently published in the last EHA meeting, and we identified that for the patients included in the ESA naive cohort, similar to COMMANDS trial, we identified that 76% of the patient reached transfusion independency with a very favorable safety profile, is not increasing the adverse event related to this drug. And interestingly, of course, for this relapse refractory cohort, 64%, near 64% of the patients reach this transfusion independency for more than 8 weeks, with an increased hemoglobin mean of more than 1 gram. And these results are amazing because it includes also ring sideroblast negative population, in which this drug is less probably effective. And of course, again, safety is not increased with no relevant adverse events. Probably several updates of this data could be in the next in the upcoming meetings. And the last role of luspatercept that is not being addressing is the role in anemic non-transfusion dependent patients, like we seen in the CINTRA-REF clinical trials in DEL5Q, move the drug to a very early initiation of the anemia. And in this setting, the ELEMENT trial performed by BMS is comparing luspatercept as EPO alpha in patients with anemia but no transfusion dependency. That is the major goal for these patients, to early treat in order to try to avoid transfusion. The second drugs in this setting is imetelstat, as all you know, because this drug has been recently approved for the treatment of lower risk patients with transfusion-dependent anemia. Based on the result of this clinical trial in the slide, this is the IMerge clinical trial in second-line treatment in patients with ring sideroblasts positive and negative. These patients receive imetelstat compared to placebo. Every imetelstat was administered intravenously every 4 weeks with a pre-medication, and the primary endpoint was also transfusion independency. Importantly, we have to compare this result with the Medalist clinical trial, but we have to take care because they are not the same patient population. I'd like to highlight that near 40% of these patients had ring sideroblasts negative, and not in that these patients was not included in the Medalist clinical trial, and also the transfusion burden of these patients was greater than the Medalist clinical trial. And here you can see that near 50% of them were in the high and very high transfusion burden. So the patient population is not the same, and we have not to clear compare with the Medalist clinical trial. In these results, we can see that very heavily transfusion patients reach durable transfusion independency. As you can see here, near 40% of the patients reach this goal of transfusion independency that was prolonged over time. Importantly, when we analyze the results in ring sideroblasts positive and ring sideroblasts negative populations, we can see that even that in ring sideroblasts populations the results were lower, but they still are very of interest in this population because they reach near 32% of transfusion independency. The median duration of this transfusion independency is very prolonged, around 1 year, and we have to take care because the safety profile is completely different to luspatercept. This drug is inducing several degrees of hematological toxicity, as you can see here in the slide. Sometimes the patient develop grade 3 and 4 of neutropenia and thrombocytopenia, but interestingly, the majority of these related cytopenias are manageable and reversible in the 4 subsequent weeks. In the majority of them, the recovery occurs after 1 month when the patient comes to the next cycle. And interestingly, these cytopenias are not associated with clinical consequences. As you can see here, there is not an increased risk of bleeding or infection. So it's only a numerical effect in the patients that generally resolve in the 4 weeks before the next cycle. This is different drugs with a different mechanism of action. It's a telomerase inhibitor and probably is a disease modifier drug in this context due to the fact that when we analyze the mutations present in the patients and evolution after treatment, we identify a decrease in the allele frequency of different mutations that are present in patients receiving imetelstat and not occurring, as you can see here in yellow, in the placebo arm. Here you can see the decrease in the median allele, in the allele frequency of patients treated with imetelstat. And probably this disease modifier activity is correlated with responses and duration of the responses. So probably this should be addressed in several other clinical trials, but probably this drug could play a role as a disease modifier drug, and probably this is the reason why these responses are very prolonged. Interestingly, for these patients, we see that even when we analyze patients receiving prior luspatercept to imetelstat, the responses are also very good for the patient. And as you can see here, when we analyze different pool of patients receiving imetelstat, we identify that even when the patient is receiving luspatercept or even ESAs and luspatercept, the rates of responses that you can see here marked in green, these are the emerged results of the phase 3 trial, are pretty similar even in these patients that have previously received luspatercept, traducing that probably the sequence of the treatment could be of this treatment could be after luspatercept failure because it's not decreasing efficacy in this with this drug. And finally, there is another approved another drug very interested and ongoing that is nowadays in phase 3 trial that is KERS-015 for the treatment of anemia. It's a novel TGF-beta inhibitor, very different from luspatercept, and administered also subcutaneously every 4 weeks. In this pool population of different types of anemia, this drug reached amazing results in the overall population, still not too much patient, 81 in this. We reached 41% of transfusion independence even in non-ring sideroblast positive patients, and even also in high transfusion burden patients in which luspatercept is not reaching a very good responses. Also, the safety profile of this drug is pretty similar to luspatercept with no relevant or severe adverse event, and we are ongoing in this phase 3 trials. And finally, to finish this lower risk setting, we have to take into account that sometimes we have lower risk patients with possibly target therapy. And in this regard, the French team is developing this clinical trial with ivosidenib for patients with transfusion-dependent anemia in relapse refractory to different treatments and with mutant IDH1. And in this small cohort of only 3 patients, because it's not a frequent disease, they reach some responses with an oral therapy during 28 days. So take into account for if you have the opportunity in one or other patient. This is the final message for the lower risk setting. The major message is that we need to treat as soon as possible, and when the patient develops symptomatic anemia, we need to start the treatment pretty soon, not waiting for the transfusion-dependent phase of the disease. And of course, if possible, try to include the patient in a clinical trial. For patients with del(5q), lenalidomide is the treatment of choice in the non-transfusion-dependent anemia and, of course, in the transfusion-dependent phase. And in the overall other population, in the non-transfusion-dependent phase of the disease, we are now waiting for the results of the ELEMENT clinical trial comparing ESAs versus luspatercept. Available, we have ESAs, and the recommendation is to try to treat the patients, not to develop transfusions, and try to use very early erythropoietic stimulating agents. When the patient is in the transfusion-dependent setting and is diagnosed with transfusion-dependent anemia, the first-line treatment should be, according to the COMMANDS trial, probably luspatercept for the majority of the patients based on the percentage of responders and, of course, the duration of the response. But we have several issues that have to take into account according to the different country authorizations or reimburse. In second line, in the MEDALIST and the IMERGE trials allow us to use 2 different drugs. In the majority of the patients, the first-line treatment should be luspatercept, especially for those in the ring sideroblast positive or with SF3B1 mutations. And after this drug, probably we should use imetelstat. And in the ring sideroblast negative or SF3B1 wild type, imetelstat is now recently approved. The problem with this drug that is not still available in Europe and probably not in also your country. And here you can see the paradigm of treatment in this subset of patients with these available drugs. Probably also we have other drugs not approved for this lower risk setting, like lenalidomide, that is only approved in del(5q), but sometimes is available for the treatment of the patient, and also hypomethylating agents analogenic for the patients younger and candidates for a transplant. And here you can see that we have to try to increase the responses with the decreased toxicity. And for this reason, we have to try to initiate early the drug, because we are going to have better responses and greater responses in the non-transfusion dependent phase of the disease, moving for the low and high transfusion, because when the disease is evolving, the probability to response is even lower. And that's all. This is my revision in the lower risk setting. And let's move to the higher risk update. This is not associated with several drugs, as all you know, because here you can see my outline and the last failure in this setting, that is venetoclax. Of course, we also have to this definition. We have to identify overall survival in these patients. High-risk patients are those with inferior overall survival, less than 30 months. And of course, we have the same issues than in the lower risk definition. And you have to take into account that patients failing to ESAs or del(5q) or lenalidomide in the del(5q) setting and progressing to the treatment very early after the initiation are going to be probably in the higher risk setting. And of course, remember the classification according to the molecular IPSS, because when we analyze especially patients in the intermediate IPSS-R, we identify that some of them are going to be restratified with a up stage. So probably in this intermediate IPSS-R patients category, we have to perform, if possible, molecular IPSS, because the majority of them, as you can see here, are going to move into these high risk categories, as you can see here in this stratification. Now, here you can see the treatment algorithm for high risk in 2025. This is the revision of Hematologica by the Nicholas Krogen. Here you can see the NCCN guidelines in 2025. And the first question that we have to address is if the patient is candidate or not to allotransplant. The majority of them, as all you know, are not candidates to allotransplant. And regarding the allotransplant, we have to identify if the patient needs to receive or not bridging therapy to the transplant with chemotherapy, hypomethylating agents, or even hypomethylating agents plus other therapies. If the patient is not candidate to transplant, the preferred treatment since 2008 is azacitidine outside clinical trials, and we have several other situations in which we can use target therapy like ivosidenib in mutant IDH1 that we are going to see later. And also new formulations of intensive care chemotherapy and venetoclax updates. Here you can see the results of azacitidine, in which we identify in 2008 the benefit of azacitidine over conventional care for patients within high-risk MDS. and is the standard, as all you know, but still the results are poor and sometimes not easily reproducible. The problem with azacitidine is that all combinations in clinical trials have failed, and we have the last one. This slide is not update because nowadays we know that venetoclax have also failed in the phase 3 trial. Here you can see some drugs very promising in these phase 1 and phase 2 clinical trials, but that failed in this phase 3 clinical trial. And this is the same results with these drugs with different mechanisms of action, even that we include a lot of patients in these clinical trials. Here you can see the pevonedistat clinical trials, including also CMML and AML with 20 to 30% of blast. The the primary endpoint was not reached because we don't identify event-free survival differences, also not overall survival differences, and even in this drug with no hematological toxicity that was added to azacitidine and the ASA dose intensity was maintained, we did not see any improvement in overall survival and responses. Regarding sabatolimab, with a different mechanism of action, this is a drug targeting TIM3, and in which more than 260 patients were included in each arm. Only focus in high-risk MDS with a low population of CML patients, and the primary endpoint was overall survival and was not reached, even that there is a trend toward to improve leukemia and progression-free survival, and that also responses were a little bit greater with sabatolimab, and this drug was not associated with relevant toxicity. The other two clinical trials based on immunotherapy was magrolimab, anti-CD47 mechanism of action, target therapy, and in this drug that target macrophage activity with also more than 500 of patients included, only focus in high-risk NDS, we identified that the overall survival and complete remission rate that was a dual primary endpoint was not reached, and even the responses were quite lower due to the high incidence of adverse events in the arm of magrolimab. So this is a very a very terrible result for the company, because an increased toxicity with no benefit in the patients were reached due to these adverse events. And other different drug is tamibarotene, a RAR alpha activator, and this drug was also planned to be associated with azacitidine in a high proportion on a number of patients. And again, we did not increase complete remission rate and, of course, overall survival secondary. And the last failed phase 3 trial, in which we are all waiting for the results, was venetoclax. Venetoclax in this clinical trial, in this phase 3, newly diagnosed high-risk MDS patients, was compared to placebo in those standard dose of 400 milligrams per day during these first 14 days. And we identify in this clinical trial that probably an improvement in the overall survival was probably could be reached, because the different scheme, not too toxic like AML, only focus in high-risk NDS, no CMML, no AML, and with this idea we started this clinical trial. Phase 1b was very promising results in high-risk NDS, and was the basis of identify the scheme doses of 400 milligrams orally for this first 14 days in a 28-day cycle. And we identified that responses with venetoclax were even higher when was associated to azacitidine that other drugs that has been performing in clinical trials in the high-risk setting. And the responses occur in more than 80% of the patients and very pretty soon after treatment. Median duration of these responses was very prolonged, and probably this drug was associated with an improving overall survival, according to the results of this phase 1 trial recently published. Interestingly, this drug has a very relevant number of adverse events related to hematological toxicity, but that was the possibility to ameliorate these results. But in real life, we are using this drug nowadays, and I can highlight here. I like to highlight the Spanish cohort of real-world evidence, because we have this drug available, and we are using sometimes in very young patients, candidates for allotransplant in a very high-risk disease, sometimes in relapse refractory setting. And we identify this in 30% patients with candidates to allotransplant. And we obtain the same results as previously described, an increase in overall response rates, up to 90% of the patient respondents responded, and the majority of them with complete responses. And this treatment was associated with a very with a manageable safety profile. We have several hematological toxicities, but the majority of these patients are able to proceed to allotransplant. That is the idea in these young patients. Also, this idea was recently published by Dr. Garcia Manero, and in this phase 1b cohort, 124 high-risk NDS patients were candidates to allotransplant. And as you can see with this scheme, the results after transplant were very, very relevant, and with a very good news for these patients, because these combinations allow us to reach transplant in these patients, and with a very good overall survival after transplant. Nevertheless, the results of the Verona trial, we don't know what happened, because the results are embargoed up to until SOHO and probably ASH meeting, but these results have failed. We cannot use in first line for the overall population venetoclax to induce more responses and more overall survival, because it's not achieved the primary endpoint, but probably several subtypes of patients. For example, transplant patients can be of benefit, can be still maintain the benefit of this combination previous to transplant. We have to wait to the results, but probably there is a subgroup of patients in which we can use this drug. And finally, in the high-risk setting, we have to take into account that sometimes we have target therapy in several subgroup of patients. And again, IDH1 mutations are not very frequent in high-risk NDS patients, but the possibility to be targeted with target therapy is of interest in these patients, because these patients with an oral therapy can reach a very relevant result. These are the results of the French study that include patients in first line and in relapse refractory setting. And as you can see here, the overall response rate are very promising, even in first line treatment, with an overall response rates of near 80% of patients, with monotherapy in the majority of them. Regarding IDH2, we have the same option. Nevertheless, the drug is not available in the majority of the countries, but also in first line plus azacitidine, or in the relapse refractory patients, we can rescue several patients with a very manageable safety profile. The main problem with the majority of these high-risk patients are the presence of TP53 mutations is probably one of the reasons that make fail the majority of the phase 3 trial, because this population is included in the overall population of high-risk patients, and sometimes it's not easy to reach response and to maintain response when the patient is TP53 mutation. So probably they should be discarded for the overall clinical trials and be analyzed in specific trials of TP53. We have to finish this novel compound, CPX351, is a novel chemotherapy available for these patients and is feasible as a bridge to transplant for patients candidates with similar responses, overall survival, toxicities, and with probably a prolonged relapse-free survival as compared to conventional chemotherapy, as you can see here in this population, and this could be an option if available for this patient. And finally, we have, of course, available now oral therapy. And in this component of oral decitabine plus venetoclax, this is a phase 1 clinical trial in 40 patients. You can see that the majority of the patients reach response, and 50% of them were candidates to allotransplant. This is a novel combination that should be tested in clinical trial, in phase 3 clinical trial, but the possibility to treat the patient with oral therapy is, of course, a very good idea. In Europe, we don't have oral decitabine for the treatment of MDS. It's available in the United States, and we are now performing different clinical trials with the novel formulation of azacitidine plus cedazuridine in a phase 3 clinical trial. And of course, there are several other target therapies for a different approach and with different targets like CD123 or novel BCL2 inhibitors, and the possibility of CAR-T therapy that seems to be in the near future. Here you can see my final message for the high risk. You have to take care with the molecular IPSS, especially for prognosis in the intermediate category of IPSS-R. The standard approach for the majority of the patient is azacitidine in monotherapy, because the failed results of all compounds in clinical trials, but the possibility probably to increase responses as bridge to transplant could be to add venetoclax in Asia plus azacitidine, or even to move to other chemotherapy, novel chemotherapy in these patients candidates to transplant. In this refractory setting, only if available clinical trial, and because the results of different targets of different drugs in this setting is are not beneficial for the patient, and consider the possibility to increase or to restore responses to azacitidine, adding venetoclax if the patient is a candidate for allotransplant, or even the target therapy in the setting of IDH1 mutations. Nowadays, there is an ongoing phase 3 trial targeting azacitidine plus ivosidenib, and we are also participating in this novel formulation of hypomethylating agents, but still waiting for the results. And that's all. Here you can see a resume of what is happening in the setting of MDS with the next generation sequencing. We are starting a novel, increasing the knowledge of MDS, starting and is emerging novel therapies in the lower risk setting, but still there is a lot of knowledge in in the higher risk setting that needs to be explored and needs to be discovered. And this is our team in the Spanish NDS team. NDS team, and this is my team in the University Hospital of Salamanca. I like to say thanks to all of them. And this is my city in which you are, of course, invited to come and to visit us. And this is our new building in our old city. And that's all. Thank you very much.
Thank you, Dr. Maria, for that wonderful lecture. A lot of information, some disappointments, failure of the studies. But yes, we have to continue and we will be successful one day. So we have a lot of colleagues here who will have their difficulties or they will like to interact with you and ask questions. And we'll also have invitation from the audience who are listening. Please put your questions in the chat box. So somebody from here would like to ask? You can raise hand or open your video and go ahead. We have a question in the chat box. Any study or comparison rather, any comparison of luspatercept with darbepoetin?
No, there is a very relevant question because we use sometimes darbepoetin, but because this drug is not approved for the treatment of NDS, is not allowed to include in clinical trials. In general, probably the responses are pretty similar to EPO alpha, so probably the responses are pretty similar, and the comparison is similar to ESAs in overall. So the comparison seems to be similar to EPO alpha. We identified that all ESAs, if they are used at higher doses, and for DARBE should be 150 or even 300 per week, it's reasonable to have the same result that the ESA, that EPO alpha. So the responses probably are pretty similar to ESAs, but no clinical trials has been performed because it's not approved for MDS. It's only approved EPO alpha.
Thank you. Another question is, what are the determinants of response to luspatercept? Do we know who responds and who does not respond?
To luspatercept, yes.
Luspatercept, response predictors.
Yes, this is a very good question because nowadays we don't have a lot of predictors.
Dr. Deeparani. Okay, fine.
Yes, probably the best responders for predictor are those related to the biology. Those patients with ring sideroblasts are going to respond better. And also the transfusion dependent, because when the patient transfusion burden, when the patient is in the low transfusion burden, the rates of response are pretty higher than in the high transfusion burden. We analyze EPO levels, and this don't have impact on response, and also other mutations and mutational profile with no impact on response. So probably with only these two, transfusion burden and the presence of SF3B1 mutations of sideroblasts, these are the two predictors for better responses.
Any comment on the use of combining erythropoietin and luspatercept?
Oh, this is an amazing question because they probably are synergistic, and we probably have greater responses, but there are still no clinical trials addressing this approach. There are some initiatives from the French team, but in relapse refractory patients, and I think that the major goal for this treatment should be in first-line treatment, for example, the combination of both ESA and LUSPA, and probably we are in a synergistic targeting erythroblast, and probably we have greater percentage of responders, but there are no clinical trials.
Okay. The other question is, in high-risk MDS, having adverse mutations like TP53 with very high VAF but low blast percentage, is there a role for HMA plus venetoclax to reduce the allele burden before we transplant them?
Yes, completely agree. I think that the patients with TP53 are going to respond shorter, probably, but they are going to respond. So if you can reach the transplant with these patients with the low allele burden, allele frequency, is better for the patient and the duration of response. And in this regard, probably an update of a very huge clinical registry trial in an international effort is being performed, the validate clinical registry, and is analyzing the role of hypomethylating agent in TP53, and adding venetoclax probably increase response rates and allow us to move the patient to transplant. So the question is yes, but we have to take care because probably the patient outcome is poor even with transplant, and a specific follow-up should be included after transplant in order to identify relapse and try to avoid this with different approach. Sometimes with the new again starting treatment with hypomethylating agents or probably ILD, we need to delay the relapses, but that probably occurs in TP53 patients. But of course, the recommendation is to this combination of hypomethylating agents plus venetoclax.
Thank you. Other question is, NGS can be done from peripheral blood or it has to be from the bone marrow?
Yes, I think that nowadays we can do it in peripheral blood. Probably there is differences between percentage of the allele frequencies, but we generally want to know how many genes are mutated and which one are mutated. So the percentage could be a little lower in peripheral blood, but the majority of them are quite similar, and sometimes we use, especially for the follow-up, in peripheral blood. Yeah.
The question whether there is a difference in the management of pediatric MDS from adult MDS.
Yes, generally in pediatric MDS, we move to transplant as soon as possible because the results of transplant in child are better with lower toxicity, and it's a curative approach. So in the pediatric setting, all patients should receive allotransplant as soon as possible. And this is the major difference with the adult patients, especially in the lower risk setting, in which we delay transplant until the disease is addressing high-risk features. In the pediatric, we move directly to transplant as soon as possible due to the lower toxicity of the transplant in the pediatric population.
Right. The other question is about how long do you wait for the efficacy of Luspa before you say that it is not working?
Yeah, it's a very good question because we have to be sure that every drug, Luspa, imetelstat, is not working on the patient, because the majority of these patients after this drug, we don't have any other option. So before retire the drug or discard the drug, we need to confirm that it's not responding the patient. And for Luspa, we have to take into account that we need to increase the dose up to 1.75, and at least with these 3 doses at the maximal dose, if the patient is not moving hemoglobin or transfusions, probably after 3 or 4 doses at the dose level of 1.75, if the patient is not developing any modification in hemoglobin or in transfusion burden, probably it's failing at patient. But we have to try to increase the doses if we don't reach transfusion independency or a decrease in transfusions, and if the patient is receiving the maximum dose for at least 3 or 4 cycles, probably is not responding.
Thank you. Dr. Amit, your question.
Thank you, ma'am, for that wonderful lecture and very hardcore disappointment regarding the Verona trial being failed in high-risk MDS. My question was very simple and very clear from your lecture that if a patient is non-transplant candidate, then not to go for venetoclax combination. And the patient is a transplant candidate, better to go for EZA plus ven in the real-world scenario, what you mentioned. My first question is basically if you're going for a transplant candidate, EZA plus ven, 14 days of EZA, can we
Yeah.
reduce the dose of EZA afterwards? And how many cycles to be given of venetoclax before going for transplant? EZA plus ven, yeah.
Yes, in our experience, that is a general approach for these high-risk patients. We use azacitidine for 7 days at the normal dose, at the approved dose, and venetoclax 14 days at 400 dose with no dose escalation and this. And we used to move to transplant after 2 or 3 cycles. It depends on the available donor or availability, probably 2, 3, or 4 cycles and move to the transplant. If the patient responds, it's important to move to transplant very early, not to delay, because probably the patient could relapse, and it's not necessary to reach a very good quality of response to reach the benefit of the transplant, because we identify that even patients that don't reach complete remission before transplant can be in a benefit for transplant over time. So probably we need to decrease the disease before transplant, but it's not necessary to reach complete remission to improve survival.
And from the 14 days of venetoclax for the first cycle, can we reduce to 10 days of venetoclax or 7 days of venetoclax from the second cycle onwards?
No, we'll try to keep the dose if the patient did not develop hematological toxicity. The majority of them are going to develop hematological toxicity, and of course you need to decrease up to 7 days probably, or even lower. It depends on the patients and the toxicity. We used to delay 1 week, and after that, if the patient is also developing hematological toxicity, we perform bone marrow, because it's very relevant to know if the patient is developing toxicity or progression. We have to identify with a bone marrow examination what is the reason of this hematological toxicity, and if this is a hematological toxicity, we need to decrease the dose of venetoclax, especially for patients in complete remission, and if it's progression, probably move to another scheme. But we have to reevaluate every cycle the response in bone marrow to be sure what is happening with these patients, candidates for curation.
Thank you, ma'am.
Thank you, Amit. The question is inhibitors in MDS. FLT3 inhibitors in MDS.
Well, this is another possibility, but the majority of the patients are not with this mutation. We have probably less than 1%. And of course, in this situation, it could be of interest to target with these drugs in combination with chemotherapy or even azacitidine, but there is not a frequent mutation in MDS.
The other one is in MDS with high blast percentage of almost 15 to 20%, and patient is not transplant eligible. Will you use HMA with ven or only HMA?
No, in Italy we don't use as a combination due to the Verona trial results, and probably only in the if the patient progress or to AML after azacitidine, probably you can add venetoclax in the second line, because probably you can reach response with azacitidine and for a while, and after progression you can add venetoclax if the patient responds. You can prolong over time the response, but in first line is not recommended due to the Verona trial. Is not improving responses and overall survival in these patients, so it's not necessary, and you are adding a lot of probably toxicity.
Thank you. Dr. Ashok Meshram, your question.
Thank you, Dr. Maria, for such a beautiful, elaborative lecture on myelodysplastic syndrome. I used luspatercept in around 4 patients of myelodysplastic syndrome with ring sideroblast and SF3 mutation. My question is regarding the FDA's extended approval for MDS with low risk on the basis of a Medalist trial. So the population of a trial which were majority of were MDS with ring sideroblast and with SF3B. So can it affects the primary endpoints of the trial?
Sorry, what is the question?
The question is the luspatercept is approved by FDA, extended approval in a low risk MDS, all types. So my question is, it works very well in MDS with ring sideroblast. So the trial population majority were MDS with ring sideroblast and with SF3B. So my question is, can this majority of population of MDS with ring sideroblast and SF3B, they responded to luspatercept. That's why the results are more towards the luspatercept end. So what's your comment on this?
You mean the results in the negative ring sideroblast population?
My question is, the majority of a population was MDS with ring sideroblast and SF3B in Mendalis trial. So they are not equally distributed other MDS patient, I believe that. So what is your comment on that?
Yes, probably this population is responding better to luspatercept, but also several patients with no these characteristics are responding also very good to luspatercept. I think that the major idea is to try to use the drug very early. And if possible, in the low transfusion burden, because it's only approved for transfusion-dependent patients. And when you use the drug in this population, or even in not enriched sideroblast positive population, if you treat the patient very early, as soon as the transfusion is initiated, and in the low transfusion burden, the responses could be very, very good. In the Maxillus trial, in which we treat patients with ring sideroblast positive and negative, at the higher dose, we can see that we are able to increase the percentage of responders because we use high doses in a very early phase of the disease. So probably the major idea is to early treat these patients with or without ring sideroblast to reach the best benefit for the drug.
Thank you very much.
You're sure? The question is, how do you treat RARST, refractory anemia with ring sideroblast with thrombocytosis?
Oh, this is a very good question, because in this population that it was included in the Medalist trial, these patients responded very good to luspatercept, even better than patients with no this phenotype. So it's approved also for this type of patients. And in this setting, sometimes we need to add hydroxyurea to decrease the number of platelets. But in general, anemia is responding very well to luspatercept. And there is a paper of Rami Rocky published after the Medalist trial analyzing this population, and responses of transfusion independences are even higher than in the overall population. So it's a very good populations to be treated with luspatercept.
And any use of JAK inhibitors?
In this population, no, we use generally sometimes hydroxyurea if the patient needs to decrease the platelets count. In Italy, no JAK2 inhibitors. Now we are using different JAK inhibitors in phase 2 and phase 3 trials in MDS lower risk patients with momelotinib is starting a phase 3 in lower risk MDS, and we'll see, because probably there is an option, but should be addressed in clinical trials. Yeah.
Thank you. The other question is whether there is any correlation between morphology and NGS.
Yes, we hope to identify different subpopulations like del5q and morphology, PTP53, excess of blast, adverse karyotype, ring sideroblast, and SF3B1 mutation. We have these three general phenotypic and genotypic diseases, and we have to identify several others, but we are still in a very heterogeneous disease, in which sometimes the patient is not having only one mutation. There is a co-mutation pattern that modify all the morphology, but we have to learn. This is the idea that I like to translate with my last slide of the iceberg, because we, with the next generation sequencing, we are starting to identify the genotype of the disease, and we have to acknowledge more and more, because we don't know what is happening in every patient, and we need to have all the information available to try to make this association. But it is still pretty soon, I think.
Yeah, thank you. Dr. Sitaram, your question?
Thank you, Dr. Campolo, for an excellent overview. My question is, it's a clinical question. I have a transplant ineligible patient who's got moderate high risk on IPSSM. His main problem is severe thrombocytopenia. Rest of the counts are okay. Any role for thrombomimetic agents like L-thrombopag in such patients?
Yes, this is a difficult question, because the trial in which TPO analogs were combined with azacitidine also failed, and the results was of futility. Patients receiving the combination of azacitidine plus L-thrombopag reached lower responses and lower overall survival. So in general, I think that the main idea is to try to treat the patient with hypomethylating agents. In this, with severe thrombopenia, we use azacitidine intravenously, because the treatment is better tolerated. And if the patient is responding, you have to take into account that this is the first cytopenia to response, and the majority of the patients reach response after 1 or 2 cycles regarding the platelets count. So probably it's better to start with monotherapy intravenously and try to reach response. If the patient is not responding and fail to hypomethylating agents, probably you should try TPO analogs in monotherapy, because different trials has demonstrated an increase in the number of platelets and decrease in transfusion requirements, and is a palliative care treatment, but probably improve quality of life in the patient after hypomethylating failure. But the combination is not recommended.
Do you worry about clonal transformation to AML in such patients if we add in thrombomimetic agents much quicker than what you would anticipate otherwise?
Is a possibility, but it's not a very good understood. Probably there is it was several alerts in the lower setting when we treat patients with TPO analogs, but at the end it was not demonstrated an increased risk of AML transformation when we use it. And in the high risk setting, there was a concern about the use of this. It's a very good question, but there was a clinical trial performed by Uwe Plattbecker in this setting, and he didn't find an increase in AML evolution. in these patients, probably you have no several options, and if you can mitigate and the effect of severe thrombocytopenia is of course of interest. Yeah.
Thank you very much. Thank you.
Thank you.
Thank you. The other question is, what is the mechanism of resistance to Luspa in patients who initially respond very well?
Yes, this is a very good question because it's still under review. We don't know. Probably the mechanism of action of the anemia in the transfusion-dependent patients is mixed. Sometimes it's with an increasing ineffective erythropoiesis and is targeted by luspatercept, but probably after time, the patient develop another mechanism of anemia more relevant for the patients, and it becomes transfusion dependent again. It's under review because we don't know what is the reason of fail. But of course, it's of interest to know because if we identify this mechanism, we can overcome this resistance. But it's difficult because even the mechanism of action is not clear correlated with the responses, and of course after failure we don't know what's happening, because when we analyze the bone marrow of these patients, we see the same percentage of ring sideroblasts, the same percentage of morphological change, so probably it's not affecting the phenotype or the genotype of the disease, and probably is mediated by different cytokines activities, but we don't know.
Thank you. Dr. Thanda, your question.
Thank you, Dr. Campbell. I'm from Myanmar. I've learned a lot from your lecture. We have experienced two patients post-auto transplant who have changed to MTS, and when they presented with cytopenia. So I'd like to know how we could manage that kind of patient post-transplant. Yeah, post-transplant MTS.
Post-transplant NDS with cytopenia?
Yes.
Yes, we sometimes have the patient after transplant develop cytopenia, yeah, but not in relapse, you mean?
No relapse. Their primary disease were in remission.
Yes, probably you should add different hematopoietic growth factors, because sometimes the patient is developing anemia or thrombocytopenia due to another issue, probably related to the therapy, the drugs that needs for allotransplant. So probably it's necessary to add EPO or even el trombopag or romiplastin to increase these cytopenias after transplant. We use it very frequent after transplant due to this toxicity.
If they have their cytogenetics were changed to complex cytogenetics, so how could you manage such kind of patients?
If the patient develop a clonal evolution, probably is progressing to a high risk MDS. So you have to confirm in another bone marrow and follow. And if the patient change for the IPSS or RPSSR or molecular IPSS, move to a high risk approach, because the majority of these probably are evolving to a more aggressive disease. Yeah.
Thank you.
Thank you. The other question is, patients who are intolerant to lenalidomide, can we use pomalidomide?
This is a very good question, but this has not been addressed in the Delphi Q setting, but if of course of interest, but we don't know, because pomalidomide has not been used in this setting due to the fact that the company did not allow us to use. We have several investigator proposals to try this drug, but no possibility to be targeted. So probably you can try, yes, because in this setting there is no option of treatment, because the majority of the clinical trials include as exclusion criteria, the developing of del(5q). So these patients has not been checked for luspatercept, imetelstat, and other drugs. So probably it should be an option. We don't know.
Dr. Pooja, your question.
Thank you, Dr. Maria. On the same lines, I want to know what is your experience with the use of lenalidomide for low-risk MDS without deletion 5q? Are you using it regularly? Because options are quite limited if we are unable to access luspatercept.
Yes, you are completely right, because this drug is available and also is very cheap, at least in Europe nowadays, and probably in your country. And we sometimes have a patients with, after ESA failure, for example, with ring sideroblast negative or even positive, not available luspatercept, and we can identify several patients for candidates for lenalidomide. I think that the best candidate is this patient with the low endogenous EPO levels. Those with less than 200 and especially less than 100 endogenous EPO level are the patients that are going to respond better to lenalidomide. We use it in the 10 milligrams per day dose schedule, and after 2 or 3 cycles, if the patient is not responding, we can discard. But this, of course, a very good option for the patients available and very cheap. And we have seen several patients responding. So the major problem is the patient did not respond. No problem, you can discard. Or even that the duration of the response is not very prolonged, less than 1 year. But if you have good luck with the patient, is I think a very good option and very available. And I move first to lenalidomide, that not move to hypomethylating agents, because the toxicity of hypomethylating agents in the lower risk setting is pretty high and probably not recommended for the majority of the patient, even if available, and also not too high price. Not recommended for the majority of the lower risk patients as lenalidomide. Yeah.
Okay. But if they don't respond to len or erythropoietin stimulating agents, then and we are not able to access luspatercept because that's cost prohibitive in our country, then the next line, would it just be to go on to as hypomethylating agent?
Yes, you can just try to transfusions and iron chelation therapy. And if the patient is in a high transfusion burden, probably you can move to hypomethylating agents. But caution with the dose, because with low doses you can reach better outcomes. And we move for only 5 days of azacitidine, even than 7 days. And with a very controlled follow-up, especially every week after the beginning, due to the fact that these patients could develop a severe cytopenias and decrease quality of life. So this is an available treatment that should be taken into account, but with very caution.
Thank you.
Thank you. A related question is, in len failure, can we add aza to len?
Well, the combination of both has not been demonstrated to be increasing responses, but probably if the patient is failing after lenalidomide in the del(5q) setting, probably is not in the very good risk, and you have to reevaluate the patient. If this patient is still in the lower risk setting, probably you should try. Probably you should try to keep on transfusion and to follow, because after time probably the patient become high risk MDS. Sometimes the reasons for len failure is the presence of TP53 mutations, and these TP53 mutations probably are associated with a higher risk of the disease. And the question is difficult, but you can add the combination with len is not recommended, because if this is failure, it's probably due to the presence of TP53 mutation and LEN is not necessary, and probably you should move for hypomethylating agents in the case of high-risk phenotype. Yeah.
Thank you. The question about iron chelation. At what level of ferritin do you start iron chelation?
Well, we used to start iron chelation as soon as the patient becomes transfusion dependent, probably with the transfusion requirements or of 10, we initiate iron chelation, and generally is associated or recommended with more than 1,000 of ferritin level. But also it's better to start early because of we mitigate the iron toxicity pretty soon, and probably the organ damage could be lower if we start very early the iron chelation. But generally, the recommendation is as soon as the patient becomes transfusion dependent, or even when the patient increase ferritin level for more than 1,000, because in refractory anemias with ring sideroblasts, sometimes the patient develop ferritin levels before transfusion dependency, and these ferritin levels could be even higher, even in the absence of transfusions.
Right. Those patients who respond to LEN, can we taper the dose or even stop?
Yes, this is a very good question, because lenalidomide sometimes can reach cytogenetic responses, and if you have the patient in cytogenetic response for at least 12 months, for example, you can discard lenalidomide over time until the patient become again anemic, and you can decrease and discard the treatment of lenalidomide for a prolonged period of time. In the Sintra-RAVE clinical trial, we have several patients that after only 2 years of treatment, they are still out of treatment with no treatment, no reinitiation of LEN, and they are still with a very good hemoglobin level on even cytogenetic responses. So the question is yes, but after a very good response, probably cytogenetic response, maintaining with LEN for at least 2 months. Yeah.
Thank you. Your comments about treating all high-risk MDS with 7+3 regimen.
We only treat with this scheme available patients for allotransplant, and we used to include fludarabine in the scheme in order to try to increase the result. There is no clinical trials validating this approach, but generally in Europe we add fludarabine in the FLAG-IDA regimen to try to increase the responses. But intensive chemotherapy is only recommended as a bridge to transplant in these high-risk patients.
Thank you. The case profile, 72 years old female, MDS MPN overlap, no blasts, JAK2 positive, ASXL1 positive. She is transplant ineligible. We should treat her with AZA or AZA plus VEN.
In general, if this is a high-risk NDS patient, probably it's better as a immunotherapy, and only after relapse or refractory move to the combination. Yeah, but you have to take into account that not only for molecular features, the patient is in a high-risk setting. You have to take care because the patient should have another adverse features more than ISA-X2, X1 mutation to be in a higher risk, because if the patient have no severe cytopenias or excess of blast, probably is not a high-risk patient at this time point. And probably we have delayed treatment with hypomethylating agents until the patient move to this high-risk profile.
Thank you. Dr. Divya, your question.
Good afternoon, madam. The talk was well elaborate, and thanks for updating us on MDS. I have a doubt. The MDS patients, when we take them for transplant, our target will be to reduce the blast count rather than improving cytopenia. So, at what cytopenia level do we proceed with the transplant?
Well, there is no level of recommendation of this cytopenia. Sometimes we need to treat the patient even with severe cytopenias. So probably as soon the message of the transplant is to be performed as soon as possible, because the patient could be in risk of progression if we don't move to transplant. So as soon as possible, you can transplant the patient, you can go to transplant. Generally, if the patient, at least in Europe, is with less than 10% of blast, we move directly to transplant without chemotherapy or without hypomethylating agent. And only in cases with more than 10% of blast, or even in some countries 5% of blast, we move to transplant after therapy. Only the therapy with the idea of decrease the risk of transformation, because while you are waiting for the donor and to preparation of the patient for the transplant, probably the disease could progress, and this is the main reason probably to treat the patient.
So even with the platelet count less than 10,000 or hemoglobin less than 7, we proceed with the transplant if the blast counts are less than 10%.
Yes, of course. These patients should be candidate to transplant. Probably you should try to increase the count if needed with transfusions or even hematopoietic growth factors, but you can proceed to transplant directly. Yeah.
Thank you.
Thank you. Dr. Rashmi, your question.
Good afternoon, ma'am. Thank you for the wonderful talk. Ma'am, I have a case to discuss. Like, this is a 21-year female, and she presented around 6 months back with pancytopenia and bone marrow shows aplasia. So she was treated with the standard guideline. And the other lineages like WBC and also in the normal range, but she is having persistent thrombocytopenia, and even the trephine biopsy showing cellularity of around 70%, but megakaryocytes are not there, and no significant dysplasia. So we recently sent the sample for NGS, and it showed mutations in the RUNX1, ETNK, and CBL genes. So your experience regarding this case, just wanted to know, like, there are no blasts, no dysplasia we could see on reviewing sites.
Probably is this rank 1 mutation is probably germline or not? Do you know the allele frequency is higher?
Yeah, it's BAF, it's higher, ma'am. It's given on the higher side.
Yes,
Around
probably is
70%.
Yes, probably it's a germline, is a RUNX1 mutation, and probably this patient should be beneficial to receive allotransplant for a non-germline mutated donor. You have to check the family for this germline mutation and probably move to transplant to treat the patient, because it seems to be a RUNX1 germline disease. Yeah.
Okay. Thank you, ma'am.
Thank you.
Dr. Divya, you have another question?
No, sir. Thank you.
Okay. Is there any role of oral azacitidine in high-risk MDS?
Well, of course, I think that this is a very, very good drug. But the current available drug that we have in Europe is CC486, and it's only available for AML. We cannot use it in MDS because it's not approved. Also in the United States, it's not approved. And the oral hypomethylating agent available is decitabine plus cedazuridine. That is only approved in USA. Now we have we are in a clinical trial with oral azacitidine plus cedazuridine, and we'll hope that in a few years we could have a move for this type of treatment in the majority of the patients. But nowadays we are not able to use oral azacitidine in this setting. Yeah, but we of course are interested to move all patients for oral therapy. Yeah.
Right. There are a couple of patient profiles. High risk MDS with TP53 mutation. Patient is on HMA. The blast percentage is low. There are ring sideroblasts. Can we help anemia with ESA or luspatercept in this setting?
Yeah, this is a very complex question because there is no clinical trials addressing this combination nowadays. And probably the disease of the anemia is more related to the high risk profile, and the patient could be benefits for hypomethylating agent as azacitidine restore erythropoiesis pretty soon. So probably the patient respond to hypomethylating agents, anemia will improve. And if the patient is responding and not with no blast and develop anemia, probably is related to toxicity, and probably you need to decrease the hypomethylating dose in order to decrease anemia. But the combination with ESAs has not been proved, and also luspatercept, it could be an option, but of course not been checked in clinical trials, so we don't know.
Right. Another case scenario is pancytopenia, transfusion dependent, blasts 2%. There is monosomy 7. Can we use azacitidine as a bridge to transplant?
Yes, of course. It seems to be a high-risk patient with an adverse cytogenetics. So probably we need to, even that the blast percentage is low, we need to reach a response before transplant, especially if we are not going to use a ablative conditioning regimen, because the patient could be older, and in the reduced intensity conditioning regimen, especially, we need to decrease the disease before transplant. So in my center, for example, if we have this patient with these characteristics, probably we start with azacitidine or azacitidine plus ven, due to the fact that this is a very cytopenic patient and probably some degree of hematological toxicity are so expected, and move to transplant after two cycles, 1 or 2 cycles. Yes.
Thank you. Another question is about elderly hypoplastic MDS. How do you manage?
It's a very difficult question because you only have probably growth factors, probably ESAs and thrombopoietic analogs to treat severe cytopenias, also GCSF, because these patients are generally not candidates to immunosuppressive therapy due to the fact that they are older and not tolerate this therapy, and the majority of them are going to be treated with only hematopoietic growth factors. Yeah, and only in the case of excess of blast, move to hypomethylating agents.
Right. Any role of danazol in MDS?
Well, there is an old drug with no clinical trials and no very good studies, prospective studies, but sometimes is no toxic and no other option. So if available and no other option, it could be, you can try. But in my experience, I've never used danazol, but I've seen several countries, like in Latin America, in which the colleagues of Latin America, sometimes they use it, and it's an option. If there is no other, you can try, because it's better than not be transfused in transfusion dependency.
Role of azacitidine maintenance post-allo transplant for a high-risk MDS.
Yes, this is a very good point, because sometimes the reason of failing after transplant is relapse. In this setting, you have to take care because toxicity of azacitidine in these patients is high, but you probably need to follow the patient with bone marrow and minimal residual disease. And if the patient is start to progress in this setting with a small clone, probably you need to start with a preventive treatment of hypomethylating agent, or even in a high-risk patient also with a TP53 allelic setting, probably you should, even in the lower, in the very early phase of the transplant, you should move to a preventive treatment to avoid relapses or delay relapses. And also, it's important to take note that if you only treat with hypomethylating agents and did not allow the patient to develop graft versus host disease, probably relapse is going to occur. So you should also treat with hypomethylating agents and add different approaches to develop graft versus leukemia effect, like infusion of lymphocyte donor or something like this, because otherwise relapse probably is the common final of this patient. So combine hypomethylating agents with immunotherapy strategies in order to induce anti-tumor effect.
Thank you. That's the last question. Thank you so much, Dr. Maria, for patiently answering all these questions.
No.
It was very enjoyable and very, very educative.
Thank you. Thank you very much for all of you and for all your interest and for letting me participate in your amazing Sunday working meetings. It's my pleasure.
Mr. Prashant, your vote of thanks.
Thank you.
Yeah. Prashant.
Thank you, sir. Yeah. Thank you very much, sir. And thank you, Dr. Maya. It was really interesting and very informative session. Even though we also got many information about the MDS and azacitidine oral, in fact, where to position that. So I must say these kind of sessions are really helpful, and I am really thankful Dr. M.B. Agarwal for giving us opportunity and his endeavor for continuous such kind of webinars. So thank you once again and have a nice Sunday weekend. Enjoy all.
Thank you. Thank you very much.
Bye.
Bye.
Thank you. Bye-bye.
Thank you very much. Thank you. Bye.
Thank you, ma'am.
Thank you. Thank you very much. Have a nice day.
Thank you, ma'am.
Thank you. Thank you. Bye.